Hi, everyone, and thanks for joining my webinar today. There's a few buttons at the top that you can ask questions, a few other things so you can kind of see your screen and ask me questions if you have any. So let me know if you have any questions. I can see who's connected right now, so let me know throughout the webinar if you have any questions, and we can go ahead and get started. So today I'm going to be talking about women's health and hormones, as you all know. This is kind of a disclaimer. Everything I recommend should still be monitored by a physician. I don't really want to treat anybody via a webinar, so just kind of a disclaimer on that. And most of you, I think all of you know who I am. So I graduated from Western Michigan University, and I obtained my Doctor of Chiropractic degree from Palmer College of Chiropractic. I've completed my diplomate through the American Board of Chiropractic Internists and also my American Clinical Board of Nutrition. And I have to sit for my board exam still, but I have completed the program hours. And I'm working at a practice that we focus on functional medicine. So I'm excited to be discussing some of this stuff with you today. All right, so the first thing I'm going to be talking about are some statistics on some of these conditions. Premenstrual syndrome, or PMS, occurs in 90% of women, and these include symptoms like bloating, headaches, and moodiness. So a lot of women will say, I have awful cravings. A lot of people actually think that cramping is normal because it happens to a lot of their friends, but it's actually not. It's typically a sign of hormone imbalance. And sometimes these can affect women so badly that they're unable to go to work or school. The next thing that we're going to be talking about is menopause. In 2015, it was noted that 50% of the women were menopausal, and by 2020, it's estimated that 45 million women will be over 65. So if we continue in that same trend of 50% of women being menopausal, that'll be over 20 million women. 80% of these women report concerns of decreased sexual satisfaction, and 60% of women between 40 and 50 are unhappy with their sex lives. So a lot of women tend to think as they get older, it's normal for their sex drive to drop or their ability to have sex to be uncommon, but it's actually not true. They shouldn't lose that desire. So a lot of women will say that they have no sex drive or that it hurts during sex. So all of these different things are symptoms that women can sometimes experience. PCOS is another thing that we're going to be discussing today, and it's estimated that 5 million women in the US suffer from this condition. The majority of these women are in their 20s and 30s, but it can actually be diagnosed in girls as young as 11, and sometimes even in girls that haven't had their first period. So a lot of women tend to think that birth control is the only way to manage their condition because that tends to be the traditional medicine route, is to prescribe birth control. Some people have had their ovaries removed, and this kind of brings up questions on whether or not women can have babies in the future. So we're going to be kind of going through the physiology of all of this just to kind of give you an idea of what I'm actually talking about. So what is a hormone? A hormone is a chemical released by a cell, gland, or an organ in one part of the body that sends out messages that can affect other cells. So how this works is the brain talks to the gonads, or the sex organs, via hormones called FSH and LH. And these messengers from the gonads talk to the cells. So some of the messengers that we'll be talking about today are going to be estrogen, progesterone, testosterone, DHEA, and androstenedione. So the normal menstrual cycle, how we're going to kind of go through how it occurs. The pituitary gland releases follicle-stimulating hormone, FSH, and luteinizing hormone, LH. FSH is responsible for the maturation of the egg inside an individual follicle during the first phase of the menstrual cycle. And this is what raises estrogen levels high enough for the release of LH. So FSH is what increases estrogen and makes it so that LH can be released. The release of LH is triggered by a peak in estrogen levels just before ovulation. LH is responsible for initiating ovulation, which is the release of the fully developed egg. And the normal menstrual cycle, after ovulation, the eggless follicle is transformed into the corpus luteum, which functions to secrete progesterone and estrogen. So this is the part of the cycle you typically hear women say that they'll get pregnant when they're ovulating. That's when you're most fertile, and that's because this follicle is transformed in the corpus luteum. So what can happen is if a woman has sex and the sperm the sperm attaches to the egg, and then the egg kind of attaches to the corpus luteum, this is what the baby will start to develop in. But if fertilization does not happen, the corpus luteum is what is shed. So it recedes, and then hormone production decreases, and menstruation occurs 2 weeks later. So the corpus luteum is what is shed during the period and what kind of initiates the bleeding to begin. So here's a picture of the female cycle. I really like this picture because I think it gives a good look at different hormones as they're changing. The top box shows the cellular changes. It shows the follicle growing, and then it kind of shows the corpus luteum being shed into the corpus albicans. The uterine cycle, as you can see, starts off kind of high during menses, and then it kind of drops and it starts to develop as you get closer and closer to menses when that is shed. And then as you can see, we're looking at estrogen and progesterone, or the purple and orange, and then luteinizing hormone and follicle stimulating hormone, the last two that I already talked about. You can see that those peak at ovulation. So that luteinizing hormone and the follicle stimulating hormone are what end up causing this estrogen to peak, as you can see at day 14. So after ovulation occurs, estrogen levels should drop, as you can kind of see on that orange line, and progesterone should start to increase. So this is what a normal female cycle should look like. And I'm going to go through some when they look abnormal in different cases. So a typical cycle is completed in about a month. And the first day of bleeding is what marks the first day of the period. So not a lot of women know actually how to track their cycle. So the first day of bleeding is day 1 of their cycle. And it's divided into 3 different phases in order of occurrence: follicular, ovulatory, and luteal. So the follicular phase lasts 10 to 14 days, and that's during that rise in estrogen. The ovulatory phase lasts about 36 hours and involves the release of an egg. So that's where that dotted line is at 14 days. And then the luteal phase lasts 14 days, and that's leading up to menses. I didn't realize that this stuck on there, but what effect does birth control have on the female cycle? So the birth control ring, pill, and implants stop the FSH and LH surge from the pituitary. So it prevents the estrogen rise and ovulation, so thus making the woman not able to get pregnant. And I'm sorry that this box is kind of stuck over that graph. It didn't convert the way I wanted it to, I guess. But as you can kind of see in this graph, the green is actually the estrogen and the red is the progesterone. So this is what a woman's cycle looks like when she's on birth control. And as you can see, compared to the last slide here, this is what the estrogen and progesterone should look like: this orange peak at ovulation, and then this purple peak during the luteal phase. And when women are on birth control, the green represents the estrogen and the red represents the progesterone. So as you can see, their hormones are pretty stagnant during the cycle. They're not going up and down much like they would during a typical cycle. So if you hormone test a woman when she's on the pill, the estrogen and progesterone will be quite low, like you can see in this picture. And that means that the pill is doing its job and she's not likely to become pregnant. But these can kind of have detrimental effects long-term on women's cycles as well when they try to come off of them. So we like to do some hormonal testing. There should always be whole hormones and metabolites measured. And typically in traditional medicine, they don't always test all of these things. It's important to look at the metabolites and the hormones themselves so that you can see how they're getting broken down. So if you look at above the pie charts on the right, you can see where there's estrogen metabolism. Those are going to be the hormones. And as those get broken down into the different metabolites, those are also going to be showing us how well the woman is detoxifying these estrogens. So this kind of comes into play later. I'll get more depth into that. This is just kind of a picture of what I like to look at on women that we run these tests in an office. So receptors. All hormones need a receptor that work like a lock and key mechanism in order for it to work properly. So this is kind of how you might imagine opening a door. So sometimes you have a key that will fit into the lock, but it won't actually open the door. and you want it to open the door. So that's the same way that these substances can look when they try to attach to these receptors. Sometimes they can attach, but they don't always initiate a response. So the slippery slope of replacement, and I'm sorry, this pink box is kind of covering up these pictures. The box on the left shows upregulation of a hormone. So what happens is when there's a little available hormone, or there's not enough of it, receptors will try and go to the surface of the cells so that they can grab more hormone. And what ends up happening is when there's too much hormone, the opposite happens, and they start bringing their receptors back into the cell. So this kind of causes a woman to have an up and down wave-like reaction to these hormones, because sometimes there's way too much and sometimes there's way too little. So this scenario can create a dependency on the administered hormone, and removing the dose of hormone usually results in a strong negative response. So this can be kind of in hormone replacement, or this can also happen in women who are taking birth control, since the body is so used to having a hormone given to it constantly, that when it's removed, it's not really sure how to respond because it's not having the influx of hormone coming in. So this is kind of a similar idea of how you would remove a patient from antidepressants, which I'm sure some of you know that it's really difficult for patients to come off those types of drugs typically because their body is so used to functioning on it. So the entire hormone axis, testing the hormones is not enough. You can have normal lab values and still have poor receptor sensitivity, negative reactive metabolites, poor clearance, and adding natural or synthetic hormones into these situations can create a worse problem. So sometimes women might have normal levels and they still feel awful. So this is kind of something that we see in traditional medicine frequently, whether it's with hormones or just other types of medications. We'll have patients come in and say, oh, well, my doctor told me that my labs look great, but I can't sleep at night. I feel awful. I have no energy, but the doctor told me my labs were great, so I must be healthy. So this is something that we also have to consider as not just the labs. We want to check out the patient's symptoms as well. And this is one of the reasons why following protocols isn't always recommended. And that's a question that I get a lot from people is, what protocol would you recommend for this patient? And that's not always something that you want to focus on because each patient has different complaints and every person is different. So we should approach them differently. I personally think that protocols are kind of what have affected the traditional medical profession so much, because they have to focus on this protocol I have to follow, and this is what I have to give someone when they come in. So I try not to use the word protocol too often because I think every patient should be treated differently depending on what their case is. So hormones, now we're going to be getting into what the actual hormones are that we're looking at and talking about. So the first one, estrogen, it's the primary female sex hormone, and it's a steroid that's built from cholesterol. So all of our hormones come from cholesterol. It's kind of at the top of the chain. So estrogen is the one we're talking about first. It can also be produced by secondarily by the liver, adrenals, and breast. So not everyone knows this, or not everyone assumes this, but men also have all of the same hormones as we do. Obviously, their levels of estrogen are lower and their levels of testosterone are lower, but as male and female, we do have the same hormones. So that's how these are kind of produced in men, and then also this would be how they're produced in women post-menopause. And it's also produced by the ovaries and during pregnancy by the placenta. And FSH, like I talked about earlier, is secreted by the pituitary to stimulate the production of estrogen. So we have 3 different estrogens that we look at. One is E1, and this is one that's dominant in menopause. So this will be higher in women that are menopausal. E2 is made from testosterone. It's the most potent, and it's the one that's dominant during years of menstruation. And E3 is made from DHEA in the liver and placenta, and it's what's dominant during pregnancy. And it's weak in terms of its hormonal response, but it's also very protective. So that's why it's high during pregnancy. So some negative effects of estrogen, it can increase body fat, it can increase salt and fluid retention, it increases blood clotting. These are some of the ones that I think are kind of the most common complaints in women. And then the increase in body fat, that's why you'll sometimes hear women say that they have changes in their weight when they take birth control because it's altering their hormones. So these are just some of the negative effects that estrogen can have if we have too much of it in our bodies. It can also affect blood sugar control. And as you can see, there's a lot of other things that it can affect on here. But there's also some positive effects of estrogen. It's neuroprotective and cardioprotective. It activates growth factor pathways that can protect the brain and the nervous system. It affects dopamine and serotonin. And dopamine and serotonin are two neurotransmitters that kind of regulate our mood. So low dopamine and low serotonin are commonly found in people with depression and with anxiety disorders. So that's why sometimes during our cycles, patients might complain about having very emotional weeks or very sensitive weeks where they feel more sad or more depressed than they typically do. And that's not that's typically due to having changes in their hormones. So if they have too little estrogen, then that can be affecting their dopamine and serotonin, and too much can kind of affect that too. So that's why we like to try and keep these regular so that women aren't having these mood changes. It can also influence sexual function along with drive and motivation, and it can promote lubrication for sexual activity. So these are all positive effects of estrogen. And we need estrogen for a lot of things. So estrogen isn't all bad. We do need it for a lot of things in our body. It helps with brain and liver function, thickens the vaginal wall. It promotes formation of female sex characteristics. So that's why when you go through puberty, women will their breasts will grow larger. They'll grow pubic hair. Those are kind of the female sex characteristics that will develop going through that process. It'll increase HDL and decrease LDL. And a good way that I like to try and remember those and keep those remembering which fats are good and which fats are bad is I like to think that HDL is happy fats. So those are your good fats, if that's an easier way for you to try and remember that. And it also can increase cholesterol in the bile, and it works with melanin regulation. So melanin is what regulates our skin color. So there's a lot of signs of estrogen dominance, and these are some of the most common things that we hear. Swollen breasts that are tender, swelling in the fingers, being more impatient, people saying that they're too bossy, getting cramps again like they did when they were younger. A lot of women will no longer get their period, or they miss their periods regularly, or they are just irregular periods. PMS syndrome PMS is also a sign of estrogen dominance. Endometriosis, as you can see, these are a lot of common things that we hear, and also it's actually because of there's too much estrogen or not enough progesterone. High estrogen also blocks thyroid function. So estrogen dominance increases the sex hormone binding globulin, which will bind to all hormones, including testosterone. So when estrogen is super high, it can increase this sex binding globulin, and that will end up it'll send receptors to different hormones, including testosterone. So if estrogen is too high, it can also affect testosterone, which is kind of more known as our male hormones. And it can also affect the thyroid, because the thyroid is also produces hormones. So when it affects those levels, that's why a lot of women, when they go through menopause, tend to develop thyroid disorders that they may not have had before, because they're having such changes in their estrogen that it's actually affecting their thyroid function as well. So that's something that I like to look at in office when a woman comes in with complaints. Is I also like to check her thyroid, because the estrogen could be affecting the thyroid, and the thyroid could actually be affecting the estrogen. So it's kind of which came first, the chicken or the egg. And I commonly see a lot of women with hormonal complaints typically have thyroid issues as well, and they don't even realize it. So some of the other players are progesterone. I've kind of talked about that a lot. It's formed by cholesterol, just like estrogen is, and it's sometimes referred to as the pregnancy hormone. And so it helps to support the uterine lining and binds to GABA receptors. And the GABA receptors are what have an influence on our neurotransmitters. So sometimes we'll hear women say that the best that they've ever felt is when they're pregnant, and they actually love being pregnant. And that's because they actually have a lot of progesterone. So that means that they're probably progesterone deficient when they're not pregnant, because during pregnancy, there's such an increase in progesterone, it makes women feel happy. And that's why people always say like, oh, you have a baby glow or the pregnancy glow, you look so happy, and that's probably because of the progesterone. Another thing that I think is kind of interesting is progestins, not progesterone. Progestins are what is used in contraception, and they aren't the same as progesterone. So these progestins are synthetic forms of progesterone, and they can actually attach to different sites. They can attach to the same binding sites, the receptor sites, as progesterone, kind of like what I was talking about with where they bind on the cells at. So they can attach where progesterone attaches, but they can also attach to places where your androgens or like your male hormones would attach to as well. So the body has really no way of controlling which one it's going to go to. Since it can attach to all of those, it can kind of cause issues in other hormones as well. So here's some research that I thought was kind of interesting. Progesterone is also considered neuroprotective. In this study on the left, it talks about the effects of progesterone on traumatic brain injuries, so in people with concussions. And it says that progesterone has a substantial properties as neuroprotective agents in humans and animals. So it kind of helps to treat traumatic brain injuries. The one on the right talks about how it can decrease cerebral edema and cellular apoptosis, and also inhibits inflammation. So it's basically in these people that are getting these brain injuries, swelling can surround the brain, and different inflammatory pathways start to occur after an injury. And especially in the brain, that's really bad, obviously, because it can affect the neurotransmitters and just the function of the brain overall. So there's actually these studies are showing that progesterone can kind of help to heal those faster. So I thought that was kind of interesting. So some of our other hormones, as you can see so on the picture on the left, you can see in the top corner that cholesterol is at the top of this chain. So this is kind of where I was saying all hormones come from cholesterol. So in this picture, we're looking at DHEA, which I have circled, and it's the most abundant steroid hormone in the body, and it's made from cholesterol. This is produced by the adrenals, brain, and sex organs. It has lots of effects. It can be antioxidant effects and anti-aging effects. So DHEA is also an important hormone that is in our body. And lastly, testosterone. So like I was saying earlier, testosterone does actually occur in us as well as in men. It's cardioprotective. It stabilizes our moods. It preserves sexual function. So it kind of that's what gives us our drive. So in earlier years in our earlier menstruating years, testosterone tends to be a little bit higher. So this kind of helps increase the drive to have sex, which is also makes sense because that's when you're in your best reproductive years, is when you're younger. So it also in men protects against prostatic hyperplasia. So not really related to women, but I thought that was kind of an interesting fact for men. So what sorts of things can cause this dysfunction? So it can be all sorts of things. It's not always the same in everybody, but sometimes it's common things that tend to cause these dysfunctions. For poor food choices, so excess sugar can lead to insulin resistance, and that can disrupt hormones. And we'll kind of get into that a little bit more with PCOS. Ubiquitous use of birth control during maturing age can have an effect on these hormones. Excessive stress or stressors in general and medications can also cause dysfunction. So now we're going to get into these irregularities in hormones. So PMS. I like this slide because I think that a lot of women can relate to it, or they know someone that can. I'm fine, I hate you, I love you, I want ice cream, come here, get away, oranges. So I think probably all of us have experienced that at one point or another. And if you haven't, then that's awesome for you. But I think everyone's kind of been through this probably at some point. Like I was saying earlier, this isn't normal part of the cycle. So it shouldn't be expected that you should have PMS. This typically occurs a week or two before menstruation. And it occurs in 30 to 40% of these menstruating women. It affects a lot of systems, so the pituitary is affected, ovaries, adrenals, thyroid, parathyroid, and pancreas can be affected as well. And it's classified typically according to symptoms that women present with, and these can include things like anxiety, carbohydrate cravings or sugar cravings, depression, and mood fluctuations. So as you can see in this picture, PMS causes elevated estrogen to progesterone ratio, can impair liver function, reduces serotonin production. So that low serotonin is kind of what can give people that depressed feeling or really sad and kind of down and out feeling. The decreased action of B6. So B vitamins are very synergistic in a lot of these hormonal pathways. So if we're low on B vitamins, it can kind of be affecting these pathways as well and makes them less efficient. And it can also cause an increased production of aldosterone, which is kind of considered one of our male hormones. But I really like this picture because I think it kind of shows you pretty well what's actually happening during PMS. So the blue line is your estrogen, and kind of like that picture I showed you earlier, it peaks right at ovulation. So as you can see, the blue goes up and then kind of comes down after ovulation happens and continues to drop as we get closer and closer to menstruation. So the solid gray line is normal progesterone. That's what it should look like during a normal cycle. There should be a drop in estrogen at ovulation, and there should start to be an increase in progesterone. The dotted gray line is abnormal progesterone. So what's happening in these cases is if there's low progesterone, as you can see in the dotted gray, and the estrogen, even if estrogen hasn't went up or down, if estrogen just stays normal, it's still dominating the progesterone. So estrogen dominance isn't always an excess of estrogen. It can actually be sometimes a deficiency in progesterone, which is causing this estrogen to be dominant. So this is what's typically happening during PMS is low progesterone and estrogen dominance. So different therapies that we might consider for these women would be to enhance liver detoxification, to supplement with B vitamins, choline and folic acid, and also B12. Magnesium actually is really helpful in treating women with PMS. Also, I know it's really difficult when women are craving their candies and cakes and stuff during their periods, but you really want to try and decrease the sugars and the carbohydrates because it helps to regulate blood sugar a little bit better. And also, taking in a lot of sugar can cause inflammation in the body, and that can just cause the cramping to be worse. Establishing proper gut flora. So there's a lot of research out there that the bacteria that exists in our gut is closely related to our brain function. And there's a lot of research that shows that different bacteria that exist can actually cause mood changes in women. So different strains can actually cause anxiety, depression, anger, and it's all based on the biology of their gut. So it's important to kind of establish the good bacteria back into their gut. Progesterone therapy, if indicated, you always want to make sure that you're looking at labs before blindly supplementing someone with hormones, even natural or synthetic. You want to consider low thyroid function, kind of like what I talked about earlier. Exercise is important. Exercise causes a release of serotonin and dopamine and makes women feel a lot better afterwards. It also can kind of help women lose weight as well. So supplementing with 5-HTP and GABA can help to increase serotonin. And other supplements that you may consider could be calcium, zinc, vitamin E, and essential fatty acids. Essential fatty acids are very anti-inflammatory. So those are something that could be good to put a woman on regardless of her PMS symptoms or not. That's something that someone can be taking daily. And it helps to kind of establish the good cholesterol versus the bad cholesterol, the HDLs versus LDLs. So the next thing we're going to be getting into is menopause. There's actually 2 stages of menopause. Not a lot of people know this, but the first one is called perimenopause. So that's a slow decline of estrogen from the ovaries. And as you can see in the graph next to it, kind of at the peak of that pink line, it says sexual maturity. You can start to see the line goes down. So this is our estrogen that we're looking at. As it slowly starts to decrease, and that's when a woman's going through perimenopause. It usually lasts around 4 years, but it can last up to 10. The average age of menopause is 52, and the diagnosis for that is 6 to 12 months without a period. So I think most women are pretty good at knowing when that's happening. And what happens is there's few follicles, so that the follicles, so the FSH and the LH that are being sent from the brain and stimulating this release that stimulates the release in estrogen, since there's not as many follicles to stimulate that, there ends up being a drop in estrogen and progesterone. So that's kind of why those start to fall as women enter menopause. And then the decreased estrogen triggers increased release of FSH and LH from the pituitary. So the body's not really sure why there isn't estrogen, so it'll kind of increase the release of FSH and LH. Menopause symptoms. I haven't been through menopause personally, but I've had some women describe the symptoms to me, and I think this meme's kind of funny. It says, it's like being a testy human volcano with PMS, only sweat pours out instead of hot lava, but people still run from you in fear of their lives. So I thought that was kind of funny. So some of the other symptoms that occur in menopause are hot flashes, I think tends to be the most common one. Breast tenderness, decreased libido, fatigue, irregular periods, of course, vaginal dryness. So like I was saying earlier, that's why we need estrogen is for vaginal lubrication. Urine leakage when coughing or sneezing, the urgency to urinate more, mood swings, and difficulty sleeping are all types of menopausal symptoms. So this research article shows that there's changes in inflammatory markers after menopause. This shows that with a decline in estrogen, it's associated with increase in pro-inflammatory cytokines. So as estrogen's decreasing, there's an increase of inflammation in the body. The magnitude of this inflammation kind of depends on the environment that the woman's exposed to. So instead of treating the woman as she's at this point when she's very inflamed and has breast tenderness and lots of pain with her cycle, it's easier to just prevent it in general. So we want to try and have a woman go through an anti-inflammatory diet or follow, take some anti-inflammatory type supplements. So like the fatty acids are very good. So preventing these types of disorders is a lot easier than trying to fix them once they're already happening. And it also makes the transition for the female a lot easier too, going through menopause. So some therapies that we'll use for menopause can include serotonin and dopamine. So this is can help with the mood changes. We want to establish proper gut flora with pro and prebiotics. So kind of similar to what I was talking about with PMS, why it's important to have good gut flora. We want to increase human growth hormone. We also want to balance hormones, and that will typically involve increasing estrogen production. So the best way to treat the body is to stimulate, or the best way to treat these hormonal dysfunctions is to have the body produce its own. We can supplement as much as we want. People are on medications, but the best way that a woman's going to respond is when her own body is producing it. So we want to try and support the secondary organs as well as the adrenals and the liver. Like I said, with the essential fatty acids, they're very anti-inflammatory. They can help decrease pain, and they're also the building blocks for hormones. So like we saw, cholesterol is what makes our hormones, and sometimes natural progesterone cream when indicated. So we don't want to just give women, even though we have ways of giving them natural hormones. So we get those from different plants, the different plant sterols. We still don't want to give it to someone if they don't need it. So that comes from a deep history taking. PCOS, so polycystic ovarian syndrome. As you can see in the picture on the left, there is a picture of a normal ovary with an enlarged follicle. So this follicle is what is released during the period. During PCOS, the woman has tons and tons of these cysts all over, and that's can cause pain. So you can see the normal versus the abnormal one. This is typically due to disruption in androgens, so there's typically a lot of those. And most of these patients 30 to 75% of these patients are actually considered obese, and the majority of them are insulin resistant. So kind of what I was talking about earlier with regulating these blood sugars, you want to make sure the patients aren't eating a lot of starchy carbohydrates and a lot of sugars, because that can lead to this insulin resistance. And carbohydrates, the reason that these are so bad is they're a step above sugars. So as a carbohydrate gets broken down, it gets broken down into sugars. So eating things like breads and pastas, and even chips and stuff, all just kind of get converted back into sugars eventually. So symptoms of PCOS can be weight gain, fatigue, unwanted hair growth. So some women will get hair kind of on their upper lip or on their chin or the side of their face maybe. Actually hair loss as well. So the hair on their head might thin or on their eyebrows might thin a little bit. Acne, pelvic pain, sleep problems, and also infertility. And what causes this to happen? So this is the insulin resistance that I was talking about. Gut infection, so high stress and gut inflammation can upregulate the hypothalamic pituitary axis or the HPA axis. And this results in high cortisol. So high cortisol can lead to weight gain, irregular cycles, and elevated androgens. So the elevated androgens are what are causing the acne and the excess hair growth. Estrogen and progesterone irregularities are common in these women. Insulin resistance, like I said, and as you can see in this picture, insulin resistance can lead to hyperinsulinemia. So it can have an effect on all of these hormones. It decreases the sex hormone binding globulin, which can actually end up increasing testosterone. And then that can lead to anovulation or the inability of a woman to ovulate, which eventually leads to decreased progesterone. So if you remember that slide where I showed you the low estrogen, that is kind of what can also affect mood. So mood in these women might not be very great either. They might have a lot of depression or anxiety. Adrenal insufficiency is when too much cortisol is being produced, and I'll kind of show you a picture of that in a minute. So here's a test of kind of what I'm going to go over with you. As you can see on the right, where I have the pink arrow at, those are all estrogens, so are E1, E2, E3. So you don't have to worry about the difference in between those. Just know that those are the estrogens. So what we're looking at on this graph is the reference range are the two yellow stars. So on E1, you can see that it's on a scale of 4 to 12, and then kind of so on and so forth for the other. That's kind of how the rest of the picture works on the page. So we want these red arrows or these red triangles to be in between the yellow stars. That's our reference range. So as you can see on this particular patient, they have super elevated estrogens. Their red triangle is out of range in every single estrogen. So this obviously is indicating estrogen dominance in this particular patient. So why it's important for us to see the metabolites as well as the hormones is to see how well it's being detoxified by the body. So estrogen breakdown goes through a couple different steps. It goes through hydroxylation and then methylation. So our three different estrogen metabolites are 2, 16, and 4. So 2 is the protective estrogen metabolite. So it's good to have those be kind of high. 16 has significant estrogenic activity, and 16 can actually be converted back into estriol, so back into our E3. So that one's not, we don't want that super high. We obviously don't want it out of the range, but it's not as detrimental as what 4 is. So 4 is the unhealthy estrogen metabolite, and increased levels of that have actually been linked with endometrial cancers, ovarian cancers, all these different breast cancers. So a high 4, the high 4 OHE1 is a bad metabolite. We do not want that high. So that's why I think that it's important to look at these as well as the estrogens, because even if we know a female's estrogen dominant, we want to see how well she's detoxifying the estrogen from her body. And in this case, this woman isn't detoxifying very well because her levels are so high, but that's due to her estrogen being so elevated. So we kind of want to work on bringing that estrogen down and then also supporting her detoxification pathways a little bit better. So that's kind of where supporting the liver also comes into play. On the left, where I have the blue arrow, these are our elevated androgens. So these are the ones that I kind of like to refer to as like our more male hormones. Same thing, you can see that the red triangle is way out of range on these ones as well. So that's kind of just looking at that. And then also, if you look down a little further, the testosterone are somewhat elevated too. So what labs should be considered for a patient with PCOS? We want to look at fasting glucose and insulin, HbA1c, and 2-hour glucose tolerance tests. We want to look at those sugars and how well her body is handling that to make sure she isn't insulin resistant. We want to look at the thyroid panel with antibodies. So we want to look at thyroid peroxidase And we also want to look at reverse T3. So this is a test that we see ran a lot on patients from traditional medical doctors. They typically run TSH, free T3, and free T4. And you can actually have thyroid disorders with those levels looking normal. The reverse T3 is kind of the inactive form of free T3. And when that's super elevated, it actually can cause a woman to have hypothyroid-like symptoms. So there might be women that have these complaints of weight gain and fatigue and inability to lose weight and constipation, classic hypothyroid symptoms, and their labs might look normal, so their doctor tells them that they're okay, and when in all reality, they didn't run reverse T3, and that could be super elevated. So checking those levels is really important, running a full thyroid panel. Prolactin is important to look at, FSH and LH. Sometimes you could consider a pelvic ultrasound if you're looking to see if these cysts are present. And I actually read an article recently that the best time of the month to do a pelvic ultrasound on someone that you believe has cysts on their ovaries or their uterus is actually right after ovulation. So around somewhere between day 15 and day 19 is the best to run that test. And we're not really taught that commonly, but that's an article that I found. And in those women, they actually had a 98% specificity in finding the cysts in women when they were tested on that date versus at any other point in their cycle. And then also hormone testing. So the pictures that I show you are a test called the Dutch test. It's dried urine. So this the reason that they do that is because the urine can actually look at the metabolites and the hormones versus a blood draw is just the hormones. So that's why we prefer the urine for these tests. So stress can lead to adrenal insufficiency. So as you can see, my red arrow is pointing to the top of this red kind of triangle looking thing. We want the patients between the two reference ranges. As you can see, there's a high range limit and a low range limit. And what happens when we're really stressed is it causes our cortisol to increase. And what can happen with that is cortisol is just constantly elevated. This can be from lack of sleep, very stressful home life or stressful job, not getting proper nutrition, eating bad nutrition puts stress on the body. So there's all sorts of things. All of us are faced with stress every day. So learning how to manage stress is very important in these patients. And once cortisol is elevated for so long, sometimes the adrenal glands will actually start to fatigue and they can no longer produce it. So you'll see a change in their DHEA where it'll be super low because all of the hormones are getting converted into cortisol instead of into DHEA. And then that affects the entire cascade of hormones beyond that as well. So treatments for PCOS would be to address gut infection, kind of what I said already in the previous slide. It's always super important to support the gut. Address insulin resistance. So if these women have problems handling their sugars, you want to work on lowering them. Decrease intake and also decrease carbohydrates. Berberine, I really like berberine. It's a really great product. We give it to a lot of our diabetic patients. It helps lower their blood glucose levels. So I've seen a lot of good results with that. Exercise is important. So I like to stress resistance training, so with weights, or also high intensity interval training or HIIT training. These will help to lose more weight by gaining muscle and losing fat. So a lot of women, when they think exercise, immediately want to jump to getting on the treadmill or getting on the elliptical. And actually, you'll lose more weight by lifting weights because you're forcing your body you're increasing the human growth hormone, and that's going to help kind of have an effect on your hormones like what I previously talked about. It'll also increase your muscle mass, which will help to ultimately decrease fat more. So the more muscle that you have, as you put more and more muscle on, even at rest, those muscles will do more work than your fat does. So they'll continue to burn more fat even when weightlifting. That's why you can sometimes see all these bodybuilders online and on TV, and these women are eating all sorts of food, but they're still really skinny. It's because they're utilizing more energy by weightlifting, using their muscles rather than kind of being in a consistent run or a consistent walk. Obviously, if that's something that women want to start with, then that's okay, but these are just more effective ways of exercise. So you want to address the stress and cortisol levels, which I kind of already talked about. Yoga is something that's really great for stress management. I've actually been doing it a lot lately, and I think that it helps me stay more focused throughout the day, and I've really enjoyed it. L-theanine is also a product that we can give to people. This will kind of help increase their serotonin in their bodies, so it'll help them feel better. L-theanine is also something you can take to kind of help with concentration. So actually supplementing it with caffeine makes its effects better. I think that's kind of interesting. You also want to improve their ovulation and progesterone. And there's different homeopathics that you can use. So bioidentical progesterones or natural progesterones, chase tree berry and vitamin B6. So like I said, those B6 vitamins are super synergistic in these hormonal pathways. So it's important to have a lot of those. And you want to reduce androgen symptoms or the male hormone-like symptoms. And spearmint tea has actually been noted to be very anti-androgenic. Just specifically spearmint. I don't know why they didn't try peppermint, but spearmint. So here's a case study for you. I kind of want you to see what I'm talking about in some of these people. So we actually have a patient who came to our office and she was bleeding for 3 months straight. So she had no stop in her period. She described it as heavy and clotty at some points, and she had a lot of pain with these periods, and sometimes they were lighter. She had a history of ovarian cysts, although she never had imaging, so we didn't have anything to specifically look at for that. She tried birth control, but she had bad side effects, so that didn't work for her. Before this, her cycle was every other month, and now she obviously has been going for 3 months straight. Normally, like I said, she had severe cramping and really bad low back pain and also diarrhea. So some labs that we took to look at her were CA-125, which is cancer antigen. We wanted to make sure that she wasn't having this severe of changing her symptoms, that she actually had cancer somewhere. The Dutch test, so that some of those pictures that I previously showed you are the Dutch test. And then we also wanted to look at her iron and ferritin to make sure that she wasn't losing too much blood. So your ferritin is your iron storage. So your liver can store iron for later on. It stores it in the form of ferritin so that when your blood iron levels start to drop, it will convert the ferritin into iron to put back into the bloodstream. So that's why it's important to look at both, because if we have low iron and high ferritin, that means that there's a conversion issue somewhere. But if we have low iron and low ferritin, we know that there's a problem with this woman either not getting enough iron or it's being eaten up by something else. So bacterial infections can actually feed off of iron. I had a patient that came in the other day and her iron and ferritin were tanked. She had very, very, very low levels of both. She had a lot of fatigue, and she actually was positive for strep. So strep can exist other places besides just the throat. It can exist in the gut as well. And her strep levels were super high. So I did not want to give her iron in this case because the iron would be feeding the infection. So I'm treating the infection before the iron. So sorry, that kind of got off track of where I was going with this, but that's why looking at iron and ferritin is important. So what we saw in this woman, and these are her actual labs, so you can actually see what we're looking at. On the left is at the purple arrow, that's looking at her progesterone. And like I said earlier, you want to be in between the two yellow stars, and she is way underneath. She's way below it. So she has very low progesterone. And if you look at her estrogen, where the pink arrow is, they're super, super high. So this woman is clearly experiencing estrogen dominance and no progesterone. This is her cycling map. So one thing that I really like about the Dutch test is there's a couple different ways you can order it. One of my favorite ways is to do the entire cycling map of the month. So we'll have a woman collect urine samples every day. Actually, she'll urinate onto a little piece of paper and that the kit comes with, and every single day it'll mark what her hormones are. After that month, she'll send them into the labs. And the labs give us a picture that looks like this. So it shows us where her levels of progesterone and estrogen are throughout the month. So it kind of shows the highs and lows. I really like this because there are times during your cycle that you feel happier or more sad or have more cravings. And this can kind of show us an idea of, halfway through my cycle, at day 16 or 7 or whatever day, if we're looking at 15, we can say, wow, I was super emotional that day. I had a lot of cravings. I felt really awful. And we can look at the graph and go, oh, it's because your estrogen was super high or because your progesterone was too low. So I think this gives a pretty good look at what's actually happening. That's why I think that these maps are so important. So with this patient, we supplemented her with a product called Progon B4LX. This kind of helps promote progesterone or increase in progesterone. Methyl Protect. So these are lots of B vitamins. They're helping to protect, help with these pathways and also protecting the body in general. And then Hormone Protect. This helps with proper estrogen metabolism. So with this patient, we gave her something to increase her progesterone, kind of something to help accelerate or protect these pathways with the Methyl Protect, the B vitamins. And then the Hormone Protect helps with the estrogen metabolism. So, and we also supported her gut. We had her taking some iron when she was getting close to, we kind of changed the dosage in iron throughout this treatment just because it was up and down with how her periods were occurring. We also addressed the gut infections. I just kind of put the hormonal aspect of it on this treatment. So that's what this is. So following up with this patient, after 1 month of being on these supplements, her period lasted for 7 days, more similar to her previous ones. She feels like she's doing better and can handle her stress better. She's still somewhat having breast tenderness and low back pain, so that's still present, but this has only been 1 month. At her 2nd month, she still had some inconsistencies in her period, but they're better than before. There's no heavy clotting noted. She's still somewhat emotional and depressed, but she thinks that it's better than it was before. And then breast tenderness and low back pain is still present, but she's starting to feel better than she did previously. At her 4-month follow-up, she was cycling every 20 days. She describes them as being very light. So there was no clotting present this time, and she thinks her emotions are a lot better, and also that her libido is returning. The reason that her cycle might have dropped to 20 days is we altered dosages throughout these follow-ups. We kind of alter them based on what the patient's feeling. So this month, she might have had a little bit too much or a little bit too little. So it's kind of a process. It's hard to fix these things in 1 month. At her 6-month follow-up, her cycles are getting closer to a month. She no longer has the breast tenderness, and she only has a little bit of low back and cramping, getting close to her cycles. Her mental and physical energy are also improved, and she feels like she actually has some pep in her life again. So this woman's quality of life has improved significantly in just 6 months after addressing this estrogen dominance that she has. So the 6-month one was actually recently this month. So we'll continue to see her get better and better, hopefully. She seems to be making pretty good progress so far. And lastly, questions. So I saw some questions popping up as I was talking, so I'm going to go through and try and answer some of them right now. If you have any questions, you can email me, and this is my phone number at my office. You can also find us on Facebook, Drug Free Doctor, and Instagram at All Natural Doc. I like to try and post a research article or something that I read every day on there, so I like to keep those pretty updated. So let me see if I can get to my questions here. All right, so one thing that I see is how much is the Dutch test, the Dutch test, and where do you get the kit? So you can get this through a place called Analytical, Dutch Analytical. That's where they have the tests at. I can attach the link. I'm going to send you guys a PDF of these slides. I can attach the link for that so that you can become set up with them as a practitioner. As chiropractors, that we actually are allowed to order these labs for our patients. So the cost varies on whether or not you're ordering it as a patient or whether you're ordering it as a doctor. And there's a couple different tests that you can order, so that kind of varies. Like I said, I'll send the link in the email to you guys. I'll attach that link. Also, I had a question about insulin resistant and diet changes and medications. So insulin resistance is due to having too much sugar. So there's so much sugar released in the body that what happens is when you eat something, it causes a release of glucose in your body. Then your pancreas is what secretes your insulin, and that reacts to help kind of counteract the sugar. The insulin is what kind of counteracts or like breaks up the sugar, to simply put. So medications can kind of, if they affect that, they synthetically try to affect the insulin for you. So I think that it can cause a lot of side effects. Obviously, medications have those side effects, but it can also, like I talked about earlier, coming off of medications with these different receptor binding sites, it makes it more difficult for a patient to come off of them. So by taking a medication that's kind of causing synthetic insulin to be produced, it makes it more difficult for the body to produce it on its own. Let me see if I have any other questions. If you guys have any other questions, go ahead and ask them right now. Otherwise, I'm pretty much done presenting. So I hope you guys enjoyed this today. I really like talking about all this stuff, and I hope to make changes in people's lives. So let me know if you have any questions on patients or labs, and I will be sure to get you guys these notes as well. Thank you very much. You guys have a great day.